Good morning, everybody, and welcome to another TIRO by MDs webinar, where each week we bring together leading experts to discuss the latest advancements in thyroid cancer and thyroid disease research. Today, we're joined by Dr. Wang. Dr. Wang is a surgical oncology. Dr. Wang completed his surgical oncology residency and fellowship in the Department of Head and Neck Surgery in Fudan University in Shanghai, China, and a research training fellowship at University of Texas MD Anderson Cancer Center. Currently, he is professor and chief director of the Department of Head and Neck Surgery in Renji Hospital in Shanghai, and serves as president-elected of the Thyroid Cancer Committee in the Chinese Society of Clinical Oncology, actively involved in drafting several Chinese guidelines for thyroid disease. We're also joined by Dr. Stephen Waguespack, professor in the Department of Endocrine Neoplasia and Hormonal Disorders at the University of Texas MD Anderson Cancer Center. Dr. Waguespack is both an adult and pediatric endocrinologist with recognized expertise in research interests in thyroid cancer, hereditary endocrine tumor syndromes, and pituitary tumors. I've had the good fortune of knowing Dr. Waguespack since fellowship, and we currently are serving as co-chairs for the revised version of the American Thyroid Association Pediatric Guidelines on the Evaluation and Management pediatric patients with thyroid nodules and differentiated thyroid cancer. Today, we're really excited to have Dr. Wang present an article that he published in 2021 in Thyroid entitled Clinical and Molecular Characterizations of Papillary Thyroid Cancer in Children and Young Adults, a multicenter retrospective study. The study looks at 217 patients and provides data that is interesting, which we're really looking forward to hearing the details about why pediatric patients may present with an increased rate of lateral neck metastasis and may have an increased rate of recurrent disease as well. I also want to mention the podcast by the THANC organization. So please be sure to turn into Voices of Wisdom, a podcast dedicated to medical professionals and thyroid cancer treatment. Each month, we explore expert insights and groundbreaking research. So catch new episodes every third Tuesday of the month to stay ahead in thyroidology. It's available on Apple Podcasts, Spotify, or your favorite podcast app. Tune in and follow the podcast today. So without further ado, thank you to Dr. Wang and Dr. Waguespack for participating, and we really look forward to the presentation. And at the end, we should have 15-20 minutes or so for questions. So please put your questions in the chat and we can present them to Dr. Wang, or we have questions as well. So thank you again to everybody for joining.
Thank you, Dr. Bauer's introduction. It's my pleasure to present my study here today. Let me share my slides. I'm from Renji Hospital, which is one of the largest general hospital in Shanghai, China. And we will celebrate our 180 years anniversary this year. Nothing to disclose. Today we'll talk about CAYA, papillary thyroid patients. CAYA refers to children, adolescents, and young adults. WHO defined the patients whose age is younger than 18 years old. The incidence rate of CAYA PTC increased through past decades. Risk factors including family history, physical exam, dietary environment change, radiation exposure, and gene alteration. CAYA PTC is also seen in hereditary disease such as APC, DICEL1, or P10 syndromes. It's long been discussed that CAYA patients is not mini-sized adult, whose clinical manifestation was more advanced than in adults. Here we launched a retrospective study in Shanghai, China to explore clinical characteristics of these patients and identify the risk factors of lateral lymph node metastasis and recurrence. Our study collected a total number of 217 patients younger than 18 years old from two top thyroid disease center and 3 largest children's hospital in Shanghai from 2006 to 2018. In our group of patients, the average age is 14 years old, and the mean tumor size is 2.5 centimeter. The male to female ratio is 1 to 3. 95% papillary thyroid cancer is classic subtypes. 44% of our patients also have Hashimoto thyroiditis, either diagnosis by high level of thyroid autoantibody or by diffuse lymphocyte infiltration in under microscope. Bilateral involvement, multifocal lesions, and extrathyroid extension are seen in nearly 1/3 of our patients. As what we expect, CAY patients have an advanced disease status. In our patients, 86% of the patients have central lymph node metastasis and 58% of lateral lymph node metastasis. We analyzed the clinical risk factors and find patients with younger age, bilateral involvement, extrathyroid extension, present of Hashimoto, and the multifocal lesions are more likely to have lateral neck lymph node metastasis. Total thyroidectomy was performed in half of our patients. During our main follow-up years of 4.6 years, 13% of our patients experienced recurrence. Large tumor size, bilateral involvement with Hashimoto, and the lateral lymph node metastasis is associated with short DFS. And for the multivariation analysis, with Hashimoto is the only independent risk factor. Furthermore, the log record analysis demonstrated that bilateral disease, lateral neck lymph node metastasis with Hashimoto and total thyroid operation is significant associated with DFS. So far, by analyzing our data, we found coexistence of Hashimoto is the only independent risk factor. But the role of Hashimoto in thyroid cancer is still controversial. Recently, a meta-analysis published in 2024 in thyroid, Dr. Pelham from Canberra Hospital in Australia shows in adult patients with Hashimoto has lower central lymph node metastasis, less extrathyroid extension, and the recurrence rate between with Hashimoto or without Hashimoto patients is no difference. But among the CAY patients, the prevalence of Hashimoto is much higher than the adults and have worse prognosis. So therefore, we raise a question, are the different caused by difference in the clinical in CAY patients is caused by difference in tumor environment. So our aim is to identify the core genes and the immunoinfiltration that drives the unique clinical presentation in younger patients. Papillary thyroid tumor samples were collected from 20 CAY patients and 10 adults and processed RNA sequencing. Numerous statistics significant in DEG, SNP, and fusion genes. The mutation landscape shows that the number of gene fusion is much higher in CAY patients than adults, while the point mutation are more common in adult patients. Further, the cluster heat map and the DEG analysis shows 134 upper grade genes and 167 downregulated genes in CAOI patients. And the DEGS are then put into functional analysis. Geocategory analysis revealed 67 risk factors. It turns out that the DNGS mainly function in biological process in the immune system, such as activation of the immune response, regulation of immune responses. The result can correspond to our previous assumption that clinical difference in CAY may be derived by tumor microenvironment. Different expression of 57 immune-related GNGs in genes and transcription level are explored. The result shows that CD24, F12, F5, and ITGA3 and the RAET1L are the only 5 genes that show significance in transcription level. All of them are undergo the verification, except for the RAET1L, because during that time, we don't have the antibody for this gene. So in the immunohistochemistry staining, we confirm the upgrade of CD24, F5, and F12, and the downregulation of ITGA3 in CAY patients. And to estimate the infiltration of immunocells, CyberSort is adopted to calculate the abundance of 22 immune cell types in individual specimens. The result shows increased infiltration of resting master cells, but decrease the resting NK cells, plasma cells, and Tregs, and which are confirmed by the immunohistochemistry. So generally, we conclude that the decrease of protective immunocells and the increase in pro-tumorigenous immunocells may contribute to the aggressive of the CAOIA papillary thyroid patient. So in conclusion of this part, our study proved the clinical manifestation of CAY thyroid cancer patients are generally advanced. With Hashimoto is the only independent risk factor of lateral lymph node metastasis and disease-free survival. The decrease in protective immune cells may be an important factor to explain the aggressive disease in those CAY patients. So what's to be next? Further, we draw a complete atlas of CAY patients in microenvironment. We conduct a single-cell RNA sequencing in 5 pairs of CAY patients and 1 pair of adult patients, and integrate them with 5 pairs of adult samples from GEO. Patch effects were removed by standard process. For validation cohort, whole transcriptome RNA sequence was also performed in 50 patients, including 40 CAY patients and 10 adults, and an additional 557 samples from TCGAs to verify the single cell gene expression based on the subcluster. The pair patient's tissue also collected to perform the multiplex immunohistochemistry to validation. As shown in this picture, based on the expression of marked genes, we identify major cell types of CD4 T cells, CD8 T cells, NK cells, B cells, myeloid cells, endothelial cells, fibroblast, and thyrocytes. To add to our previous finding, cluster of endocellular cells and fibroblasts are further explored. For the endothelial cells, we identified 5 major subtypes of endocellular cells in papillary thyroid cancer tumor. As shown in the figure, capillary endocellular cells and tip endocellular cells are the 2 major subcluster in CAYA patients, the infiltrate rate of which is both higher in children than in those in adults. The general pathway of angiogenesis, tumor proliferation, migration, VEGF production, VEGFR function are more active in endothelial cells of CAYA. And that indicates the pathway related to angiogenesis is one of the important among those young patients and maybe serve potential treatment targets. And for the cancer-associated fibroblast, 4 major subtypes of cancer-associated fibroblast was identified in papillary thyroid cancer tumor. EM-CUF is found highly infiltrated in CAY patients, while the I-CUF is relatively lower compared to the adult patients. High EM-CUF and low I-CUF infiltration in CAY patients then stand with their markers gene by multiplexed immunohistochemistry. On the left side, we can see the brown, the green signal of LAMP5 is much stronger. This is the EM-CUF marker, well expressed in CAY patients, represent the higher EM-CUF infiltration. And the orange signal is FBLN1, which represents the I-CUF is much weaker in CAY patients. Following the enrichment analysis, compare the gene expression level for each CUF population. The rich EM-CUF in CAY patients is highly function in the pathway to promote tumor progress, such as angiogenesis, EMT-p53 pathway, whereas the less infiltration I-CUF is mainly involved in immune response. These indicate that immune regulation function of CUFs may be weaker in children, then they can facilitate the tumor angiogenesis and EMT process in papillary thyroid carcinoma. As mentioned before, our validation cohort of bulky RNA sequencing and the TCA database. In the validation cohort, high EM-CUF infiltration indicated short OS and short PFS in overall thyroid patients. And we found the EM-CUF infiltration is closely related to T stage and aggressive pathologic variants, especially the diffuse sclerosis variants, which is the most common subtypes in CAYA patients. And compared to other CUF substrate, expression of FAP gene is significantly higher in EM-CUF. Expression of FAP highly correlated with the EM-CUF mark genes LAMP5. For clinical perspective, the high level of FAP positive related to higher N stage and the T stage, and shorter PFS as well. So high expression of FAP is verified by the immunostaining in tumor tissues. Since CAYA patients have featured higher level of EM-CUF infiltration and the FAP expression, FAP inhibitor, FAPI PET scan shows potential diagnosis value. This is a 12 years old papillary thyroid carcinoma patient. We adopt with FNA diagnosis. We compare her preoperative FAPI scan and FDG scan images. We can see clear and better uptake of FAPI scan than compared to the FDG PET. So we believe that the FAPI scan can be a potential diagnosis, diagnostic and target treatment option for the CAY papillary thyroid cancer patients in the future. So finally, I will make a quick summary. Single-cell RNA sequencing reveals active angiogenesis in CAY patients, which may serve as a potential treatment target. High infiltration of EM-CAF in CAY patients indicated shorter OS and PFS. Elevated FAP level in EM-CAF brings potential diagnosis value of FAPI PET scan in CAY thyroid cancer patients. Finally, I would like to give my sincere thanks to all the colleagues who contribute to our study. Though they are from different cancer centers, but that they did a great job in supporting our study. Again, I have nothing to disclose. Thank you for listening.
Thank you, Dr. Yep. Thank you, Dr. Wang, for a very, very interesting, intriguing presentation, both on your original article, which I think we can start with questions with that, okay, and then the additional research you've done since then, which is really interesting and is complicated. Will take a little bit of digesting. It's hard to go through in real time, but I came up at least with a couple questions, and maybe Stephen as well. So really, really nice work. It's interesting in our practice, back to the 2021 paper, that you had such a one high rate of patients with Hashimoto's, 40%, and that's in the paper. The diagnosis was based on positive antibodies and heterogeneity in ultrasound, but when on the surgical path, did you have the opportunity, because it's 200 path samples, to look to see if it correlated? Did it actually look like Hashimoto's under the microscope as well?
Yes.
Yeah. So there's germinal centers and significant lymphocytic infiltration.
Mm-hmm. Yes.
Yeah. And then the histopath range for the types of PTC is also interesting, as 95% papillary thyroid cancer. Although in your current data, you had some patients, it looks like, that had tall cell and diffuse sclerosing variant also. And the age of the patients is 14, right? The average age in that initial study, the mean age. When you did the fusion analysis, did you happen to also look at the somatic drivers to try to figure out if it's classic PTC and if 100E may have been, or fusion driven classic PTC? Was that part of the analysis, and would that change and be a potential independent factor also for predicting lymph node mets, is the direct question.
That's a very good point. And in our 2021 papers, the average of age of our patients is relatively older. The mean is 14 years old. And we found that younger patients, the fusion is more common in younger patients. And we know the diffuse sclerosis variotypes are associated with the NTRK fusion or RET fusion. So the younger patient may more have fusion, and the younger patient may be more aggressive than the adult patient, and maybe more Hashimoto's.
It's interesting.
Yeah, to expand on that, and thank you, Dr. Wang, for a fascinating presentation and for exposing us to newer technologies and FAPI and things that we need to learn about, for sure. So yeah, I was interested. I think your average age is pretty typical. So I'm not sure I would call it older. I think most institutions will have that as their average age. So of course, at that average age, you're going to have more BRAF V600E mutated tumors compared with fusions. But I was to just ask additional questions about genotype correlations. I mean, it would be interesting to see, you know, what the genotypes were, the drivers is what I mean. And like Andy said, is that an independent association? Because, you know, they all kind of come together, right? Like diffuse sclerosing variants tend to have fusions, and they're defined by lymphocytic infiltration, right, under the microscope as well. So did you have a chance to look at the specific driver and correlate with outcomes or even the presence or absence of Hashimoto thyroiditis?
At that time, we don't have enough data to find out the drive gene to associate with this. And now we are collecting more patients. We now have 350, around 350 patients, and we include them as much as younger patients into our cohort. And we will check all the gene backgrounds for, because there's a paper published in JCI that less than 10, younger than 10 years old, maybe 90% of the patients are fusion type. And older than, I think is 14 years old, they are more like the adults, BRAF mutation patients. So I think when we do the assessment, the guideline, we think below 18 years old is too wide range of the ages. We need to separate all those pediatric patients into subgroups, like less than, younger than 10 years old, 10 to 15 years old, or older than 14 years old. These subgroups maybe have different clinical characterization, and maybe we need to treat them differently.
That's a very good point and an ongoing discussion. I think all of us pick less than 10 years of age just to try to come up with pubertal status, once pre-pubertal, once pubertal. But there's been a couple papers now, is 14 to your, you know, for the median age for your cohort in the 2021 study. Is that another cut point rather than 10 to 15? So should it be less than 10? I don't know what to do with 10 to 14 and then 14 older, or should it be less than 14? You know, we struggle trying to figure out what that age is, and how do you define it? Is it clinical? Are they gone through puberty, or just starting puberty, or are they pre-pubertal, or is it based on driver? I don't, any thoughts from the two? Like, how are we gonna ever define that? And then how do you treat them clinically, right? Because you can't talk to a 14-year-old the same as you can talk to an 18-year-old, right? It's not only the science, but it's in practice. How do we manage these patients?
And the reality, it's also when they're diagnosed, right? Because we'll see people in their 20s that we call, they have pediatric thyroid cancer, but you know, they've had cancer for 10 years. So sometimes age is arbitrary because you don't quite know the onset of the disease. Under 10 you do, but otherwise, you know, it's kind of hard to distinguish sometimes.
Dr. Wang, in China, for your guidelines, are you coming up with a different age for how to define pediatrics? And are you thinking about those?
Now we cut line is 14 years old.
14.
I'm sorry, I accidentally muted.
Because it's also controversial in adult thyroid cancer management. That's ipsilateral thyroidectomy or total thyroidectomy. We think the younger patients, more fusion, they more likely to have bilateral or multifocal lesions. We will recommend the younger patients for total thyroidectomy, but for the older than 14 years old, we can do some hemithyroidectomy and not do the radioactive iodine treatment after.
Well, continuing on that line of thought, you know, it's interesting that 51% of your patients were initially treated with lobectomy. Right. So can you share with us the kind of the clinical approach to those patients? So they all went back and had completion, or can you tell us a little bit more about that?
After 4.7 years, that's 13 patients recurrence, all distant metastasis. All these patients, we will come back to reoperate on them. And as I mentioned before, in this cohort, the patient is, the age is relatively older. So it's close to the management for the adults. There's no lymph node metastasis or there's unilateral lesions. We will do hemithyroidectomy, not the total thyroidectomy. Because in China already, I think in the early, we adopted the hemithyroidectomy more early in thyroid cancer patients.
Yeah. And we definitely like that. I'd support that thought process. So if I'm hearing correctly, so not every patient in the study had a total thyroidectomy and radioactive iodine. So there's some people in the outcomes part of your study that were just treated with lobectomy.
Yes, yeah, I think 44 patients lobectomy.
Okay.
Mhm.
And do you know roughly how many of those had Hashimoto's versus?
The total cohort is 44%. We not separate those total or not total with Hashimoto at that time.
Okay, yeah, just be interesting because if there are a good subset of those with Hashimoto's, I'm assuming their outcomes are good because you didn't go back and have to do a completion. So
it's different with adult patients. In adult patients, we see Hashimoto may be a protective factor of treatment.
and I know Andy and I, we had talked about this. So can you share with us how you defined recurrence in your population?
Yes, through the image like ultrasound and CT scans.
So it was structural disease.
Yes, right. Because you don't do total thyroidectomy, the thyroid globulin is not a marker for recurrence.
Right, of course.
Right.
Only structural.
Well, yeah. Well, hopefully you guys can publish your lobectomy outcomes. I think that would be very valuable addition to the literature.
Yes, but we are trying to put the gene background for these patients. So it's we need to redo some gene text for these tumor samples.
Yeah, the approach is interesting, and I think in each of our environments, countries,
Yeah.
we have a different approach, and there's clear advantages to lobectomy, of course, both surgical complication rates and the potential need for replacement, levothyroxine replacement therapy. But then we struggle with what's the likelihood of bilateral disease, which, there was a fair number in your cohort. And the comfort level for the families. I think it's culturally, and it may be just because of our approach has been this way for decades. What are people willing, families willing to deal with as far as the certainty of that the cancer is gone? So if you have a patient with unilateral disease, even if they have on ultrasound lateral neck metastasis, you would still approach, and they're less than 10, you would do a total, but if they're 14 or older, you would do a lobectomy. Is that what
No. For the lateral neck disease, we will do total because
you do a total?
Yes, the intermediate or the high risk patients. Right. We need radioactive iodine. So if there's lateral, so we are studying on the risk factor of lateral lymph node metastasis to see which kind of patient need to do the total.
And the ultrasounds, are you performing in clinic or your radiology department's performing? And who does the preoperative?
We have special ultrasound doctors. They also do FNA for ultrasound doctors. We also do PET scan to verify if there's metastatics of the lateral neck.
For all pediatric patients?
Mostly all pediatric patients.
That'd be interesting data too. You have a lot of interesting data we'd love to see.
Yeah.
We got the CT scan is more, the specific level is higher, positive rate is higher than ultrasound because ultrasound depends on the experience of ultrasound.
Correct.
Yeah.
And so you're doing CT with IV contrast, which
Yes.
again, we've been trying to promote that is,
Of
it
the
doesn't
patient.
delay care. Right,
But
that it's an
if
okay.
we will do after operation radioactive iodine treatment, we always wait like 1 or 1.5 months. So the contrast drug is already
Cleared.
on.
Right. No, we agree with that. It's just hard to convince people because of older data that says you have to wait, months when the more contemporary data suggests that's not true.
And also for surgeons, we want to see the image because
Good.
ultra images we cannot see those. We only see the paper, right?
Yeah.
But the CT scan we can see it to find out when the lymph node is missing.
Absolutely.
Yeah, that's wonderful. If you do a lobectomy and you don't see anything on ultrasound, this is like personal questions because we're working on our guidelines. Then would you do a prophylactic central neck dissection or only do a neck dissection if they had detectable disease preoperatively on ultrasound or CT in the central neck?
In China, it's different to United States. We do all the thyroid patients, we do prophylactic central neck dissection. All the patients. Now depends on the T stage. Even T1, we do the prophylactic central dissection because you cannot correctly find out the metastasis through the ultrasound because the lymph nodes are very small. And if the patient with Hashimoto, you cannot differentiate the large lymph node is metastatic and also if the patient's recurrence at the central neck, the reoperate will cause more complications, right? Because you need to refine the nerve, you need to protect the parathyroid gland. So we all do the prophylactic central neck for every thyroid cancer patients.
And that makes sense because of your high rate of N1A disease. So that would explain that there's always more than meets the eye, I think, in terms of lymph node mets. So
can I ask one follow-up question, Stephen? Unless you were going to ask it. So if you do that, how many lymph nodes would be positive to say you're going to go back and do a completion on a prophylactic central neck?
That's a good question. You need to discuss with the patient and the family because it's a Chinese patient don't want to do second operation if you have to. So we will talk about them and most of the patients will wait and see if there's a lateral neck or there's a control lateral gland disease, we will do a second operation.
Yeah, and that's been our approach at my institution as well recently. And so yeah, I think would be very valuable for you to publish your lobectomy outcomes because I'm sure a good percentage of those have central neck disease where you didn't go back appropriately because you could just wait it out.
A follow-on study of the Sagino paper from Japan, which was excellent also, which is the same approach, lobectomy, prophylactic central neck in pediatrics. And another paper would be really helpful because that's a wonderful paper and your data sounds very contributory.
I still think we need to focus on the age, compare the younger, and also if there's a BRAF mutation or fusion, we need to compare, we need to divide into two groups.
But
I agree with all of that.
Age may not matter as much as just what your clinical presentation is, right? So, sometimes I'm a little resistant with age just because if you have a 5-year-old with a 1 centimeter tumor, no lymph node mets, right? That's still a possibility of doing a lobectomy. So, but I think it's just more the correlation that younger patients are going to have more macroscopic lymph node disease. That's just how they present. And so, so age as an independent, risk factor, I think we still have to understand that. I did have a couple of questions, just some basic things. So, obviously you had 20 samples. And so, part of the analysis may be limited by sample size. Do you think the results are going to be the same as you continue to gather more samples? Or do you think the sample size limitation is something that we need to think about as we interpret the data?
So we do the single cell sequencing for this. I think maybe it's more correct to choose the microenvironment through the single cell study, because for the RNA sequencing, maybe the sample is too limited, and maybe not enough to show the real mechanism of immuno environments. So we are focused on single cell.
And teasing out, right? That's why single cell is important too, teasing out the contribution of the cancer versus the microenvironment, right? In terms of what you see on your sequencing results.
Mm-hmm.
Yeah. So, your data is very, very compelling. And, for forever, we've struggled with this paradox that's inherent to pediatric thyroid cancer, that children present with more advanced disease, but they don't die of thyroid cancer.
Yes.
So, your data suggesting that it's, the microenvironment's immune regulation that allows them to get this more advanced clinical presentation. But why don't they die then? Why do they still have good long-term outcomes if they have this inherent issue with immune regulation?
Yes, it's a question always puzzles us, But yeah, it's I think maybe the gene backgrounds. So in this presentation, we not include the thyroid site single cell sequencing for the shows the data. We see the thyroid site is quite different, also quite different in pediatric patients than the adults. And I think the fusion, we don't see any third mutation in our pediatric patients.
Mm-hmm.
So we are working on how these thyroid tumor from differentiated to undifferentiated. What's the mechanism to see? Maybe our pediatric patients, the tumor cells always be differentiated. So they will never go to poorly differentiated or anaplastic, so they don't die.
Mm-hmm. Mm-hmm.
Right.
But the mechanism for this, we are still working on.
Yeah.
As part of your gene analysis, have you looked at the thyroid differentiation score and
right.
kinase signaling?
We will publish the data in the future.
Good.
Stay tuned. Yeah, because I always thought, because people, we've always been thinking like, what's the difference? So we know there's genomic differences in cancers. We know there's, and part of that is just the underlying fusions versus BRAF. We know that pediatric cancers don't get TERT promoter or other secondary mutations that increase the aggressiveness. But part of me always has wondered too, well, do kids just have a more robust immune system that is protective? And so I always would think, that someone with Hashimoto's might have better outcomes because their body's already primed to attack the thyroid antigens, right? That's expressed. So that's why it's just interesting to see that your data doesn't show that in terms of at least the short-term recurrences and outcomes.
So maybe the lymph cells infiltrate to the tumor is different in adult patients or in the pediatric patients. So that's different Hashimoto, I think.
Yeah. Or if you could find a cohort of adult patients with poor prognosis, didn't fare well, that de-differentiated to compare what their gene expression profile is, either single cell or from the initial type of analysis you did in the 2021 paper. It won't tell us why, but at least you'd see what the differences would be. Because I wonder if the immune system is the cause of it or just a consequence of whatever the difference is, right? Why the pediatric patients maintain differentiation.
Yeah.
Lots of stuff to learn. This is such an important addition.
Yeah, I think especially the microenvironment experiments are very, very interesting. I didn't have time to digest it all, so I don't think I have many intelligent questions right now. But I was interested. I'd never heard of a MAPI PET. Is that something like what is that being applied to these days?
FAPI PET.
Oh, FAPI. I'm sorry, I kept FAPI.
Yeah, they are doing prostate cancer. They do a lot of FAPI PETs because the fibroblast will express the FAPI protein. So we find the FAPI protein is higher in diffuse sclerosis variotypes. So this patient is diffuse, and actually this patient is ETV6 NTRK3 fusion patient. So they have higher EM-cuff, higher FAPI protein. So we will the FAPI PET will help us to find out the tumor. Even we will early find the lung mets. The patient finally have lung mets, not seen in the CT scan, but we see in FAPI PETs. So it's a very helpful scanning for those patients.
That's interesting because it sounds like that's more representing the underlying fibrosis, right, of the tumor. So that's retained even in distant mets, that they'll have these enhanced fibroblasts and things.
Yeah, they will help you to decide if the patient needs a total thyroid.
No, but I'm surprised that they would be so expressed in lung mets. Particularly, your typical pediatric patient's going to have, micronodular disease that's even sometimes below the sensitivity, the threshold of PET uptake.
We already have 3 NTRK fusion patients use the FAPI PET to find the lung mets.
Okay, interesting.
Yeah.
Wow.
3 patients. We are doing a launch clinical research for FAPI PETs in adult pediatric thyroid cancer patients. We already collect like 30 patients already.
So 2 questions with that. One's just approach to care and logistics. So for all pediatric patients, whether that indeterminate cytology or consistent with malignancy, you're getting preoperative somatic oncogene testing, it sounds like, because that's the only way you could decide which patient would undergo or benefit from a FAPI PET or other, more.
We have a multi-gene panel for these FNA samples. So for pediatric patients, we will do the multi.
For all patients.
For all the pediatric patients, because they are not BRAF mutation patients. You only do BRAF, they will be negative. And also for the cytologic, they always give you undetermined diagnosis. They don't give you like a papillary thyroid cancer or other various variant subtypes diagnosis. So all the pediatric patients, we will do multi-gene panel.
Yeah, that's a struggle everywhere. To your point earlier, ultrasound is very subjective. Cytology is very subjective. And for us, the practice at institutes where we have very accurate and very experienced cytopathologists, we're more comfortable, but that's very different. Intra-observer variability across institutes is very subjective. The oncogene, I think, some people believe, it sounds like you follow the same, is more objective, more informative. And the follow-on question is, if they have fusions, have you had any patients that have gone on oncogene-specific inhibitors? And is there any difference in response?
Okay, actually, the targeted therapy drug are limited in China. We only have RET fusion, RET inhibitors and NTRK inhibitors, new drug. But
for pediatrics, that's okay. Sorry, Steve.
it's not approved with CFDA yet. We only can do clinical trials for these patients. So we are not widely used in the clinic, but in clinical trials, we are doing this. But the pediatric patients are relatively good results. They only have stable disease. Only few patients with progressed disease. So we are not, we don't have any experience for these patients for target therapy. But in the future, I think we will follow all these patients and to see if there are any candidates for the like NTRK fusion PD patients. We will use the NTRK inhibitor.
Inhibitory therapy. We have a prospective study looking at to see if it pre-radioactive iodine for patients with pulmonary metastasis, if it increases efficacy to
So
try to
it's
reduce the population with stable disease.
like neoadjuvant radioiodine therapy, right?
Correct. Yeah. And Stephen's involved. We're involved in a couple other centers in the States and North America.
Interesting. Good.
Oh, I'm sorry. Go ahead.
No, go ahead, Stephen.
No, I was just following up on the distant Mets discussion. So in the end, do you remember what percentage of your children had distant metastases?
Around 10%. The
Around-
younger have more.
Okay.
Mm-hmm.
And if you look just at those 10, how many of those had Hashimoto thyroiditis?
I can remember how many Hashimoto's. I will check the data.
I'm asking you about data from like 3 or 4 years ago. So
In that paper, we not focus on the recurrence. We only to see the lateral lymph node metastasis and disease-free survival. Yeah, not collected the radioactive iodine treatment data in this paper. We are still working on it.
Yeah. The single cell research, which all of us will need to digest more once it's published.
Send out for review. Yeah.
The data, like the activated pathways for angiogenesis and EMT, would certainly go along with explaining why pediatric patients have an increased rate for lateral neck metastasis and pulmonary metastasis. I think in one of the slides, though, you mentioned about P53 also. So that was in the MCAF, that it promotes progression and there's alterations in P53 signaling. Was that what that slide was? It went by quickly.
We do the signal pathway analysis. It's concentrated on several pathways, including one of this is P53. And the strongest one is angiogenesis. So we think angiogenesis VEGF receptor may be a potential target for these patients. P53 is only one of these pathways we found.
Right. So if they maintain differentiation, we'd be surprised, right, to see mutations anyway in TP53.
This
really fascinating.
It's not exactly it's the same for P53. It's the P53 pathways. Yeah.
The pathway, right, not the gene. Right. It went by quickly. I just saw it. I'm like, oh, that's interesting. I didn't see if there's any other questions. Do you have any other questions, Stephen? I didn't see in the chat. Let me see.
Yeah, I don't see any in the chat. I did just think of something though. Again, you won't know the answer to it, but this is just, something you guys could look at is, over time, right? I'm assuming your kids with Hashimoto's most likely had thyroglobulin antibodies, may or may not have, right? But it'd be interesting to see if the patterns of thyroglobulin antibody clearance correlate with outcomes as well, because, I would anticipate that those who no longer have antibody production, right, may be different than those that have persistent. I don't know. I'm just thinking out loud. to see how do you correlate that baseline Hashimoto's to outcomes, and what happens over time, and does it still is it still a persistent risk 5 years after diagnosis as it is at diagnosis, if that makes sense.
The antibody is always a problem for our clinic.
Right.
Just to evaluate the status of the patient. It's persistent there for a long time. Even you do the total thyroidectomy and radioactive iodine, the antibody is still.
Yeah. Sometimes they'll clear. They will clear quickly, but we also have some patients too who develop antibodies upon long-term follow-up, which is always a conundrum as well. And I'm not sure what that means. So a lot more to learn, of course.
So may I ask a question? In the United States, all the pediatric thyroid patients do the gene test before surgery?
No.
No. So we're trying to promote that for indeterminate cytology. That's the current our insurance may approve that, but it's not a guarantee. And so in the States, we still struggle with multiple insurances, whether they're state-based or whether they're private, and what's going to be improved. And for the most part, adult and pediatric, Stephen can correct me, it's for indeterminate cytology. I think for us that are so focused on thyroidology, to your point, I think there really is benefit to knowing even in Bethesda 5 or 6 because of the variability in cytopathology. And is a 5 really a 5? Is a 6 really a 6? And the oncogene would provide objective data. But it's difficult, and every patient is its own challenge. You're never a guarantee to get oncogene testing done. The Children's Oncology Group will now do free oncogene testing, but post-surgery, but not preoperatively, where it may be the most effective or most informative.
And importantly, we don't yet know that the oncogene should drive the treatment decisions either, right? I mean, I think all three of us believe in ipsilateral central necks if you're doing a lobectomy. So, and given the high rate of lymph node disease, right, whether they're BRAF or fusion, you're still going to probably remove those lymph nodes. So I don't know if it quite yet changes. It wouldn't force me personally to do a total on someone whom I think is a good candidate for a lobectomy.
Okay.
That's why your data, Dr. Wang, would be great, because you're doing preoperative, you're changing your surgical approach, and to see that outcome would be a wonderful addition.
Yeah. So lots of work to do, Dr. Wang.
Yeah.
This is the beginning, hopefully, the beginning of a conversation.
Maybe the testing price is the key, right? Yeah, we do a 8 fusion gene panel. It's around $400, so it's quite cheap. We can do this. Yeah,
that's not us. That's not our reality. It's probably 10 times that, right?
I know. Yes.
All right.
So I think we're getting close to the end. Someone asked about quality of life studies in lobectomy versus total. So if you're doing any validated, quality of life assessments, I think most of us see that it should be better, but obviously, formalized data on that is always important, and it's going to be different across cultures and countries. But that was one of the questions in the chat. But I think, again, in the quality of life, it's the burden of surveillance, knowing if it's clear and you're in remission versus the benefit of low complications and potential no need for lifelong levothyroxine. So it's 9 o'clock. I just want to say thank you, Dr. Wang. Really interesting data. Thank you for your time. I know it's Friday night in your world.
Yes.
Starting our workday here. So we hope you have a wonderful weekend. I encourage people to come back next week. There's Tumor Board on the 16th of August. Dr. Int'l is moderating and Dr. Erkin is presenting. The TIRO expert website is something that is encouraged and really informative. And I think every time we have the opportunity to present at TIRO by MDs, the pediatric thing, it really helps our community. So thank you to the THANC Foundation for including pediatrics. And thank you to Stephen for joining us as well. And to our participants, of course.